Okay, I'll get started.
Yeah.
So, hey guys, and welcome back. Today we have a very special guest who is Christina's new best friend. So, I've been pushed to the side, and her name is Dr. Mara Gordon, who is a weight inclusive doctor in the Philly area. So, Mara, thank you so much for coming on the show today. We're really excited to talk about weight inclusive care and some really kind of insidious stuff about insurance billing and how patients can empower themselves with weight inclusive care. And we're really happy to have you on today. So, thank you for coming.
Thank you so much. And I'm a big fan of your work. So I'm very happy to be in community with you both.
Yes. I think one of the things that we were really interested in is hearing a little bit about what was the turning point that made you shift from a weight centric approach to a more weight neutral one. And we'd love to hear about that journey as a physician.
Yeah. Thanks for asking. So I'm a family doctor in practice in Camden, New Jersey, and I see both adults and kids. And I describe my practice style tongue in cheek as I don't yell at my patients to lose weight. And I laugh. It shouldn't be that hard. That shouldn't be the sort of that we're starting from. But unfortunately it is. I think so many people's experiences of healthcare are really centered around just a very weight centric approach, the weight first approach. And just associate a visit to the doctor with an audit of their body size. And I was trained that way, frankly. Throughout med school and residency, I think I was taught to have a very weight focused approach and advocate for weight loss at every visit with my primary care patients. And like many changes over time, my shift to a less weight focused approach was very gradual, right? It wasn't one lightning bolt moment. And maybe I wish it were because I think it's important to acknowledge that there's a lot of harm that I perpetuated, I think, in that approach. And part of my advocacy work around size inclusive medicine is trying to undo some of that harm. And so yeah, it was a gradual approach. I think there were three threads that came together for me was noticing that it didn't seem to be doing much good to tell my patients to lose weight. I'd say I was trained. I would say, have you thought about hopping on the treadmill more often? And I could see patients' faces disengage. I could kind of see them check out. I could feel my trust slipping away or their trust for me. And I just noticed this pattern again. And I also noticed that it wasn't doing any good, right? Like this kind of counseling wasn't helping them lose weight, which was the stated goal. And now I don't even necessarily think that is a, a goal that is useful for many of my patients. But when it was the goal, it wasn't achieving it. And it didn't seem to be averting any other health problems, right? It didn't seem to be preventing diabetes. It didn't seem to be preventing hypertension. It just was. So noticing this pattern over and over again was the first step. And then the second was reading, honestly. So reading some works by thought authors that really started to change my thinking. Many of them wrote about interactions and with healthcare that were, I was very humbled and saddened to recognize myself in some of the negative experiences that they wrote about with doctors, specifically the works of Roxane Gay, Kisei Lemon, Lindy West, all of those. They wrote memoirs that I read maybe, I don't know, 5 to 7 years ago that were really formative in my thinking. And then also part of it is my own body changing. I gave birth in 2021. I gained weight after giving birth. And like many people do, almost everybody does. And I think realizing that my approach wasn't necessarily, I couldn't take my own advice. I was doling out this advice and yet it wasn't working for my own body and slowly grappling with the idea that maybe the advice was bad. Those three threads have been coming together over the last several years and have helped me start to reconceptualize my practice as being weight neutral.
Yeah. That's really
Yeah.
wonderful. And I love hearing the honesty of the evolution because I think sometimes in these circles, a lot of times it comes back to doctors are the ones who causing the problem, or it's part of the, of course, part of the problem is the training and everything, right? And the way that fat phobia is so insidious in medical literature and the way that we approach things and stuff like that. But I really love how you noticed even through your own evolution of, oh wow, maybe we could do this differently. And I'm seeing these patterns and wanting to do something about it. It's one thing to kind of become complacent and say, well, this is the game, versus someone who's saying, hey, I don't really like doing this anymore. And most people don't go into medicine with the idea of what you're describing with feeling like you're getting a disconnection between your patients. That's not
Yeah.
why people go into it. Most people go into medicine to help people and to want to have a connection with other people. And so I think it's really beautiful that you acknowledge, hey, this doesn't feel connecting. And I'm wondering too of then how has weight inclusive care and this weight neutral approach been changing as we've started to see this rise in Ozempic and the GLP-1s and all of that, and how has that impacted your practice now?
A lot. So I would say I've been doing this pretty quietly for years, I think at this point. And maybe it speaks to my own internalized fat phobia that I have been writing for news organizations for years at this point, because I was a medical student as a freelance writer and medical journalist. And I've been writing about every medical topic under the sun except this one. And it's somebody pointed that out to me recently. And I was, wow, maybe it was my own fear um, of touching this third rail. So yeah, I was quietly practicing a more size inclusive approach to medicine, I would say, over the last 5 to 6 years. And I didn't write anything about it. I didn't post anything on social media. I was just kind of seeing what it felt like to not bring up weight. And it kind of felt a revolution of omission, right? Just that people didn't even notice that they were feeling bad before. But then if it wasn't something that I brought up, it just made everything go smoother. And I could see that I gained people's trust more. I started writing about this publicly once Ozempic was kind of on the scene. So I haven't really, yeah, I've been engaged in a public dialogue about this sort of in the context of GLP-1 agonists being available for weight loss. And there's a big practice changing study that came out in the New England Journal of Medicine, which is probably the world's most prestigious medical journal, that showed that this class of medication, GLP-1 agonists, which I've been using for years, I've been using them the entire time I've been in medical practice to treat diabetes, could be used for weight loss at higher doses than we have been using for diabetes. So that's what this big article showed. And it came out in 2021. And I remember looking at the abstract and thinking, oh my God, somebody's going to get really rich off of this. And
They
shocker, I
have.
was right. To cut delayed by maybe a year or so. And people started coming to me asking for them. And I had a very disorienting experience of advocating for size inclusive medicine. I had started writing about this and speaking about this issue. And then I got all of these new patients who say, oh, I've read your work, Dr. Gordon. I'm here because you're a size inclusive doctor. Can you give me Ozempic? And I was like, whoa. And it took me a while to understand that um, people were looking for a non-judgmental doctor, but they still wanted to lose weight, right? Because we live in a very fat phobic society. And it took some learning and some reflecting and some gentleness on my part to understand that's actually pretty normal, and how to treat those people with gentleness and with love and kindness is really important, rather than saying, have you been listening to anything I've been saying? And that's not a therapeutic approach, right? But it was disorienting to me at first. I was, wait, am I not communicating clearly about what it means to have a size inclusive approach? Yeah, what's going on? And I have a lot of patients who sought me out specifically because I'm a size inclusive doctor, but then say, hey, can you prescribe me GLP-1 agonists? So there's a lot of discordant thinking. There's a lot of cognitive dissonance, I think. And I think that there's a lot of people out there who are acknowledge that fat phobia is a major problem for everybody, but yet they still want to lose weight. And I think that's a pretty normal response to the way that our society functions. You know what I mean?
And
Yeah.
Christina and I run into this all the time
All the
in
time.
private practice, and then also even with our podcast community, because we talked about this frequently, but they're in the nutrition and kind of health world, which exactly as you experience, there's a side that's like, hey, you've gained weight, you're the worst, here's all these solutions. If you don't take these tools and they don't work for you, then it's actually your fault, not the tool's fault. And then on the other side of things, specifically more in the anti-diet extreme body positivity end of things, people really feel when they're a patient or a client kind of trying to figure out where they enter onto this spectrum of the space, they a lot of the time feel like they are in that no man's land, because okay, well, I don't want to participate in institutionalized fat phobia, racism, white supremacy, all of the buzzwords on this side of things, but at the same time, since we have been raised in this society which is extremely fat phobic from all different aspects, the prospect of, oh, just accept your body as it is not very accessible or appealing to them. Further, in the anti diet spaces, it can seem like if you have a desire to lose weight, you are not welcome here, even though that's not the intention at all. And so we will get a lot of people who it sounds like have a similar experience, and we have a similar experience to you is, hey, I don't want to be judged for the fact that I want to lose weight, but I want to know how to do this in a non-extreme kind of way. And it's interesting because I think when people first hear about what all of us do, they may assume, oh, you are never ever going to work on weight loss with people. You'll never ever work with someone who wants to be on a GLP-1 agonist or anything, when really that's not an inclusive practice at all. But I
No.
completely agree with you on the cognitive dissonance end of things as a practitioner. That's just like, wait a minute, have you not been listening to everything that I've been saying? Because I'm trying to not cause harm anymore, but you can still work on causing less harm. Christina always talks about like harm reduction approach, especially with her eating
Mhm.
disorder clients. But it's a really interesting internal conflict to be having. And that's part of the reason why we wanted to have you on today, because we work through this from the nutrition perspective, but as a medical doctor, it's completely different because we don't have access to prescribe anything, to diagnose
Hmm.
people with anything, right? We're kind of on the other end of things. But you, as a medical provider, people are coming to you, hey, can you give me one of the GLP ones? Can you help me with this? And so it's got to be just a hard place to be.
Yeah, I think it's really wise that you point to the principle of harm reduction, which I find to be just a foundational sort of guiding principle of everything in primary care. Just to briefly define it, it's a term that really comes from the addiction medicine community and has its origins in needle exchanges. So the idea is ideally we'd have a world where people aren't using injection drugs, right? Because they can cause a lot of harm. But if people aren't ready to stop using drugs, let's reduce their risk of getting HIV or hepatitis C, right? And have access to clean drug use supplies, clean needles, yeah. And that principle, I remember learning about it as a medical student, as a resident, and going to volunteer with some needle exchanges in the Philly area and really internalizing this idea of, wow, my goal as a healthcare provider is to help reduce harm. Such a beautiful principle for almost everything in primary care. And a patient needs a renewal on her birth control. And what I learned in medical school is you always do a pregnancy test before you prescribe birth control, right? You don't want to accidentally have somebody with an unintended pregnancy and then put them on birth control. And a harm reduction approach is, hey, you can't come in. You don't have transportation to come to my office to do that. I'm going to trust you to buy a pregnancy test at the dollar store and do it at home and tell me the results. And it's just about trusting patients, trusting clients. And you don't want to take this one blood pressure medicine. Let's try to get you on one that maybe doesn't work as well, but you're happier with the side effect profile or whatever. Blood pressure medicines maybe aren't as sexy as addiction or whatever, but this is my bread and butter in primary care. And I think this idea of harm reduction is so useful for discussions around body size and intentional weight loss. It's just how can I support the patient with what they need at this time? How can I support them in the way that they conceive of their own health, right? What are their health goals? How can I help them clarify their own health goals? And how can I reduce their chance of harm?
Yeah.
So thank you for bringing that up. That's such an important
Yeah,
principle.
I think
Yeah.
I work a lot with eating disorders because it just felt so to me, it felt really natural to fall into harm reduction because sometimes I only see them at one point in their journey in their eating disorder and they have a long way to go. And I might want them over here running through the field, eating foods with no problem and feeling great about their body and all of the different things. But I might only see them for one segment of that entire journey. And it's not up to me to decide where they end up in their journey. That's up to their own agency and body autonomy. And so I think it's important to take that same type of approach when it comes to the introduction of things Ozempic and GLP-1s and all of these things, especially the ones as we're using them for weight loss. I'm saying all of those with the understanding that we're using this for weight loss, not for type 2 diabetes management. It's completely or type diabetes management. I'm looking at it only from a weight loss perspective when people are asking for it and wanting to get on it. But one of the things that I always found when I'm navigating those types of conversations is I think it actually makes a lot of sense that people are coming to us, because I'm seeing every single one of my clients talking about this. Not every single one, but a lot of them coming in talking about this and having these types of conversations, because it actually gets to be a dialogue. When you're going to a weight inclusive practitioner, they're going to have these more nuanced conversations. And the way that I always go about it was, well, one, it makes a lot of sense that you want to lose weight. It makes a lot of sense that you want to reject fat phobia and diet culture and all of these things, and at the same time still feel this really deep internal pain to protect yourself from it. It makes complete sense to me. And so I think it's really interesting, and I'd love to hear how you navigate those types of conversations with your with your patients, maybe it's parents, who request Ozempic and stuff. And how are you navigating those? Because I always go back to, what does informed consent look like? And how can
Hmm.
I inform them so that they can make uh, a decision based off of knowing all the facts at play?
Yeah. The answer is there's not just one approach. I
Yeah.
mean, truly, every patient is different. And as I'm sure from your own clinical work. And I'm always just humbled by how, yeah, clinical medicine keeps you on your toes. Just everybody's different. I think I and I will say I practice in a low income community of color in Camden. I would say the vast majority of my patients are publicly insured. Yeah, most people have no idea what body positivity is. Dual practice of caring for the community near my clinic who don't listen to your podcast. I'm
Yeah,
sorry,
no,
right? You
yeah,
know, and it's
they could. It's for
and
free.
but I do feel there's some class and gender issues I think are worth diving into, honestly, right? That I think the body positivity movement is often seen as a movement of white women, and part of my interest is also making it more inclusive. I'm a white woman, but I remember talking to a friend of color, and I was telling her about some of this work, and she was Mara. I don't care about size 14 white ladies making peace with their bodies. Let's talk about how to make this more inclusive. And I was there, right? Guilty as charged, right? And so I think that like absolute majority of my patients have never heard of, they're vaguely aware of body positivity, but do not seek me out as body positive patient. They come in and they say, am I a healthy weight, doc? Or it looks like I gained 5 pounds, doc. What do I do? How do I get healthy? These are very sort of 101 level conversations where I say, I don't care about the number on the scale. And people are just shocked when I say that. Or I don't think weight is the most important measure when we're assessing your health. And people are, what are you talking about? This is unhealthy, right? And so yes, that's 95% of the time. I do have patients who tend to have more tend to have that privilege, right? Have the ability to travel to a doctor, have the ability to pick a doctor who specifically seek me out for this type of care. They're often driving from further away to come see me. Those patients will often come in saying, I'm here because I want weight neutral medicine. I'm here because I don't want to be weighed. And that we're starting the conversation from a baseline shared understanding that is a little bit different.
Hmm.
So all that being said, your question was, how do I approach these conversations? So I think having some knowledge of where the patient's coming from, what their knowledge is about size inclusive medicine, are they on board? Or are they coming from a place of total newness to the topic? And so a patient will say, I really want to lose weight. This happens 5 times a day,
Hmm.
10 times a day. And truly, it's amazing. I think so many people associate a visit to the doctor with an assessment. And that's just what primary care is to them, which is very disturbing because I have a lot of other skills that I went to school for a very long time for that I would love to offer you. And so usually my first question is, I try to ask it a little more nicely than that. But so the doc, I really want to lose weight. And I'll say, so tell me what some of your goals are. And sometimes they even have a hard time getting past that question. Well, I want to be healthy. And I say, well, what does that mean to you? What does healthy mean? And they say, losing weight. And it is often this circular conversation. It's really the fat phobia is just so deep in our culture. And sometimes we can dig a little bit deeper and get into questions of, I want to be able to keep up with my kids is a very common response I hear. Or I don't want to get winded while I clean the house. I get that, even though I hope you have other goals other than just cleaning. But that's another common thing. I feel out of breath or tired when I'm trying to do my daily routines in the house. And so drilling into those a little bit is the next step. And I think often the treatment for those kind of concerns around energy levels, around exercise capacity levels. And the treatment often is exercise, right?
Mhm.
And that can get a little tricky because the word exercise is just so synonymous also with weight loss. So I'll say, oh, well, have you thought about trying to gradually start increasing how much you can walk every day, working in a morning walk, working in a walk after dinner? And people will say, oh, but I've been trying and I'm too fat. I want to lose weight. Right. So it's often these very circular, very patient conversations that need to take place over multiple visits. That's where I start. And that can be hard. It's really tricky. And people aren't used to hearing this idea that health can be defined by other factors other than their body mass index.
So I wanted to try and change gears a little bit because I think there's a really important conversation to be had
Mhm.
about insurance.
We're on this.
We always are on the same page, Christina. But so
Talk
speaking
about
of this,
access.
yes, speaking of access and then also the internal conflict for providers, right? I would love to talk a little bit more about insurance billing and coding. And listeners, before you're, what the hell is
Tune
she
up.
talking
I know.
about? This is actually really
Yeah.
important and fascinating if you don't know about this in terms of institutionalized and medical weight stigma. So I would love if you could talk about the hierarchy of coding, the risk adjustment factor, and then
Mm.
why it is beneficial financially for some doctors to put certain codes over other ones, and why that matters to us as the patients in terms of weight inclusive care and the experience that we may have with a practitioner.
Yeah, this is a pet issue of mine. I didn't know I was so passionate about medical documentation, but I am. And I'm actually working on a paper for a medical journal about this with some colleagues. It's wild. So let me try to explain it in as listener friendly a way as possible because it can get real boring real fast.
We can
But
also link to your Substack article where
Yeah.
you explain
thank
it in
you.
more
Sure.
detail. So
Yeah, that's great. But there's so much to say. That's really just the tip of the iceberg. So the medical record is a wild place. And I think originally its purpose was to help physicians and nurses communicate with one another, but it's really evolved in the last 30 years, probably. Certainly the entire time I've been in practice, it has been a very complicated digital beast that serves a lot of different purposes. And I would say often physician communication is probably one of the last purposes it serves, right? So I was trained, oh, writing a good note about your patient is a way to communicate your thinking, to communicate what you're worried about, to communicate your plan so that other doctors understand it. But it's also used for billing so that my institution can bill your insurance when you come to see me. And it's also used for liability protection. So if a doctor gets sued by a patient, that there's all of this extra stuff in there that is designed to ultimately help protect the doctor from a lawsuit. Oh, look, the doctor actually tried to do the right thing. And here's all of this sort of documentation for it. I think it also has other purposes, research, a lot of compliance issues with state, yeah, sort of regulatory bodies. Basically, it is this mammoth like thing that just does a lot. And so patients can be confused by that because, and frankly, doctors are to talk to any doctor and they will talk your ear off about how much they hate the computer program that we use. And it can be confusing to patients. Most patients have access to their medical records now, which I think overall is a great thing. Really helps patients stay engaged in care, make sure that they understand the plan, and you should be able to see everything that your doctor writes about you via the patient portal with a few limited exceptions, but it's really pretty widespread now. So patients may be confused when they see just tons of information there and that we didn't talk about any of this. Where is this all coming from? And the answer is it's a lot of complex forces are dumping a lot of extra junk in there that's not really related to the conversation that you and I had
Mhm.
for 20 minutes when you came in to talk about your cold or whatever. And so all this is to say, that was kind of a long-winded response, that there is a lot of emphasis on encouraging doctors to document obesity as a diagnosis. And mostly this has to do with billing and the idea that if you document a certain BMI as a medical diagnosis, that it makes the patient appear more complex. And therefore, doctors may get reimbursed more money for a visit with somebody who meets that criteria. And there's lots of nuances to this too. It depends on what type of insurance you have, what type of medical visit it is. There's a lot in the weeds that we could get into, but I get emails every month saying, don't forget to document obesity, truly. Saying, make sure that to all the doctors, make sure you're documenting patient complexity. And here are examples of, quote, patient complexity and obesity. Stop me if I'm is it?
Soaking it
Yes.
all up because
Yeah.
to be honest, I'm really happy that we're talking about it, and I want you to go back to it because I actually think in some ways this actually one empowers the patients to understand and people who are listening to understand the mechanisms at play that are happening. And two, it also provides a little bit more of and I'm sure we'll get to it, a little bit more guidance about how do you handle this with your unique practitioner. And maybe they're not as sometimes people come to say, oh, look what my doctor did. And it's, oh, well, maybe it wasn't them.
Yeah. So, yeah, there's a lot of
Yeah,
forces at
maybe
play
there's a
here
lot
that
of
are
layers. Yeah.
totally, yeah. So, and then of course it triggers printouts that you get when you leave the doctor about, oh, here's diet and exercise, and which we know actually are not particularly effective for weight loss, although they are great for protecting cardiovascular health, good things, but it's just so silly, right? And even in the computer interface that I use, which I try to show to patients, I'll turn the computer so they can see what I'm doing. So that why is she just staring at the computer? I try to shared document during the visits. And although there's so much in there that people don't even know where to look. I mean,
Yeah.
it's wild how busy the screen is, but their BMI, if it's over 26, is highlighted red in the medical record, which is just crazy to me. It's everybody, almost everybody comes in as a BMI over 26. And I don't think it's pathologic. Just for the record, having a BMI over 26 is not, it's normal. And I don't think it means that you have a medical illness, but the medical record treats it as such, the computer treats it as such. And I get these pop-ups saying, don't forget to document obesity as I'm trying to navigate through the chart. And so my practice, which I'm happy to talk through, is that I basically just don't do that. And I ignore all the pop-ups. I do this as an activist thing. I really hope my boss isn't listening, that just don't document body mass index as a diagnosis, with one exception, which is that after a discussion, informed consent, and a patient wants to try a GLP-1 agonist for intentional weight loss, and not for any other reason. They don't have diabetes. They don't have cardiovascular disease. They don't have another indication for a GLP-1 agonist other than trying to lose weight. Then I will document a diagnosis, obesity or overweight. And I usually tell the patient, right, so that they're prepared that they're going to see it in their printouts. Yeah, there's just a lot of systemic forces that are really built into the digital environment that is such a part of modern medicine that really perpetuate fat phobia every step of the way. And I think people don't really understand that when they go to the doctor.
No,
And
they
that is
don't.
that is one thing I wanted to bring up too, speaking of the or sneaky things, because in the Substack article that we referenced, you talked about what you call the sneakiest form of medical weight stigma, which is when patient will go in and you'll have, not you, but another doctor will have an appointment with them and they don't talk about weight at all. They don't talk about weight loss or suggestions or anything. And then it shows up in their chart and in their medical record. And then all of a sudden, you just said, you're getting all these different recommendations for diet and exercise and all these different things for weight loss. And the patient is basically blindsided because we never talked about this at all. But then that happens because it was included on the billing for insurance. And it's so sneaky. And this has happened, I think, to both Christina and I at some point in our lives. And I remember Christina was having a rage hour when this happened after her session. She was like, the hell is going on? They didn't even talk to me about this and blah, 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 blah. And it happens to even us. And it's such a frustrating place to be in. But I'm glad to be talking about this because I think it can help people have a little bit more understanding of why it's happening. It's not even necessarily always meant to be a harmful thing or meant to be, hey, you should pursue weight loss for this and this. Oh, I stubbed my big toe. Hey, have you ever thought about losing weight? Because that's what a lot of people feel when they go to the doctor as well. So I'm appreciating that we're having this conversation.
Yeah. And I'm so sorry that's happened to you guys. It's happened to me.
It's everywhere.
And I will say also that even though I don't document it as a diagnosis, that's something that the doctor has to actually do. The printouts automatically have BMI. Here, your vital signs hurts. Here's your blood pressure. Here's your BMI. And I have no control over that.
Yeah.
And it feels a little bit throwing at my hands, but I can't even explain how complicated the computer program is and how many people are trying to get it changed all the time and update it. It feels like a cruise ship that's steering in one direction and trying to move it is really hard, right? I mean, it's just this massive entity. And I think, again, speaks to this idea of systemic fat phobia. This is an example of a system that is very complex, has lots of different stakeholders, and really hard to make change
Yeah.
within it, right? So even as my activist self who refuses to put in the diagnosis of obesity or overweight, I still, my patients get the handouts that say BMI. And I try to warn them, particularly if I'm aware that the patient has a history of disordered eating or sort of like attuned to this. I'll say, like, listen, I'm sorry, this is going to come up, but yeah, it's a mess.
Yeah, I talked to a lot of my clients about that. I said, okay, we're going to the doctor. This is going to happen. Let's be prepared for all of these things. Here's how we're going to protect ourselves, how we're going to safeguard it, what we're going to talk about after the fact if it comes up. What are we going to do to protect ourselves and your recovery? So I think also too, one of the things too that kind of doesn't solve the issue by any means, right? But like you said, it's a cruise ship that's moving, is having that knowledge of, hey, heads up. I think a lot of times that is one of the biggest things that can happen. I just recently went through this with a client of mine with a severe eating disorder, and they went to their doctor, and we talked about it ad nauseum beforehand. And after the fact, they were able to say to me, I felt it was more annoying than it was impactful because now I went into the session, went into the doctor's office with eyes wide open. I knew what to expect. And yes, it was disheartening and they didn't want to have that happen. And I wish people were more eating disorder informed. I wish the cruise ship was more eating disorder and disordered eating informed. I wish the whole system was, but it's not. And but it is important to prepare them. And so speaking of advocacy, in one of your recent-ish Instagram posts, you wrote, if you live in a bigger body, you can demand better from your doctor. And I'd love for you to take a moment, if with knowing this information for the people who are hearing it and listening to it, how can they demand better from their doctor?
Yeah, thank you for asking. So I mean, I think I'll start by just saying that we need to do better in healthcare, and it's not our patients' jobs to fix healthcare. And that's part of the work that I'm doing, the advocacy work that I'm doing. But there are some practical steps that you can take to try to have a better experience when you go to the doctor. And I think I also want to acknowledge, I think there's a lot of doctors are human beings, and I think most of us want to do the right thing. I don't think we wake up saying, well, I want to make my patients feel terrible. And I think, unfortunately, the real common thread in so much in US healthcare in 2024 is just scarcity of time, right? We're under such corporate pressure, right? Healthcare is just corporate to a degree that my grandfather, who was an internist, would never have recognized. Just what is this corporate entity that Mara works for? I don't think he would have even acknowledged it as being medicine. It's so morphed from what medicine was 30, 40 years ago. And so I think a lot of doctors are just trying to see as many patients as they possibly can in a day because that's what we are forced to do. And we pause if patients feel empowered to take a moment and pause and say, hey, I need this out of our visit. I need this from you. Let's get off of the routine bandwagon. I think a lot of doctors will be open to that. I think we're just so busy that a lot of people aren't thinking about it, which is not an excuse. We should be. There's a lot of harm that's perpetuated by our system as it exists. But I think more doctors need to be open to these conversations than people imagine. And Christina, hearing that it takes a full sort of session to gear up for a doctor's appointment just makes me feel really sad. Yeah, I just don't think that's why most of us go into this field. And so to understand that people have so much, um, yeah, so much trauma associated with a visit to the doctor is horrible and further proof that this work is so important. But anyway, okay, so all that being said, so you should feel empowered to bring up these conversations. I think many doctors will be more receptive to them than you initially might imagine. And that we're human beings. Most of us want to do the right thing. And so just pausing and saying, hey, I am really looking for less of a weight focused approach. Weight is not something that I want to talk about today. That will often go a really long way. It can feel really scary. And yeah, it can feel scary, but I think that many doctors will be open to it. I think the first step is probably doing some research, right? And there are doctors who identify as health at every size aligned is a term that you'll see. Size inclusive is a term that you'll see. And just a shout out to, I'm involved in a new organization called the Association for Weight and Size Inclusive Medicine, aka Awesome. And we're a new professional home for healthcare providers who, physicians, physician assistants, nurse practitioners who are aligned with a weight neutral approach to medicine. And one day I hope we'll have a directory. That's actually like an enormous undertaking, and we're a long way off from that, but maybe one day we'll have it. But yeah, often doctors will have written on their profile, I'm a health at every size doctor. So just some basic asking around, some Googling help as sort of a starting point. Um, you should also feel empowered to call ahead. That's one thing you can do too. You probably will not be able to get the doctor on the phone, unfortunately, but you can get their office staff, right? And I've been doing this work and my front desk staff is, oh yeah, we know Dr. Gordon is into that thing where she does lane patients. Yeah. And so I think doctors who are building a practice around this, you should be able to probably get somebody on the phone who can say, this doctor has experience with people who have a history of disordered eating or yeah, and the front desk staff may not know the buzzword size inclusive or may not know the buzzword health at every size, but you may be able to just get a little more information about, oh, is this an area of interest for the doctor?
Mhm.
You cannot get weighed. You don't have to agree to any medical procedure. You just don't, right? It is a core principle of medicine, of bodily autonomy, right? So you do not have to agree to any part of the process. I have heard some horror stories about people who really get bullied into this. And often it's not by the doctor, it's by a medical assistant or somebody's earlier in the process. And that I'm honestly not surprised to hear. I think there's sometimes a culture of, oh, I'm worried the staff member says, oh, I'm worried the doctor's going to be mad at me for not doing my job if I agree to this. But I think if you persist and you say, listen, I'm happy to discuss this with the doctor, but I find it really upsetting to look at my weight or something that I think you should be able to not be weighed. There are some exceptions to this. I haven't gone totally weight free in my clinic for a variety of reasons. I get worried when people lose weight really fast, and it can be a useful data point. I see a lot of children, and kids should be gaining weight. So I like to see the trajectory of weight gain in kids. So I haven't gone, oh, I've completely given up weighing, but if I have a patient who in particular wants to decline it, I have no problem with that. And many doctors, I think, will be open to that, or at least open to negotiating. Hey, maybe this is something that we can do once a year. And the doctor should explain their reasoning. Medicine, we say every test should change management, right? You should never order a test on a patient that isn't going to change the way that you take care of them. And weight is one of those. So say, how's this going to change the way that you take care of me? Might be a question you can ask.
That's a
Like
good way of
how will
phrasing
it
it.
change the plan?
Yeah, that's
Yeah,
interesting.
totally. How will it change the plan? Yeah. Or another thing is also you can turn around
Yeah.
to get weighed. And I've heard this from the eating disorder community. They're blinded scales where it doesn't number. Unfortunately do not have one in my clinic, but
It's a little
you
post-it
don't have
note
to look
over
at
the
the weight.
top.
Yeah. I
Yeah,
even tell some of my clients so they don't even have to ask that they can bring their own post-it and pop it right on top and
totally.
then take it
Yeah,
off afterwards. And um, so yeah, there's definitely ways that you can do it. If you don't feel comfortable asking, you can just do it. And usually
totally.
I haven't found people to get a lot of pushback for doing that.
Yeah. What other advice do you give your clients about preparing for a doctor's visit? That's some of my basic
Oh, yeah.
advice.
Dana, do you
Yeah.
have any? Mine are
Yeah.
like kind of talked about mine, but mine are more than just one session. I'm sorry. Mara, like I gotta tell you, it's usually
Yeah,
more it's
that's so upsetting to
like it will
hear. I mean,
be, to be
yeah,
honest, it's in some cases it's convincing them to even go and spending the time. No, this is really important. Preventative healthcare. We need to know what's going on inside your body. We need to stay informed about what's going on. So a lot of times it's leading up to it. So there's a lot of sessions discussing going back and
it breaks my heart.
finding
I
a
mean,
doctor and all of the things. And I've even called ahead
totally.
and talked to the doctors, all the things. So I do a lot of advocacy on their behalf with my clients, especially my high risk ones. But Dana, I'd to hear yours because your patient load is so different than mine. You have so many people with chronic health issues and GI stuff. And I'd love to.
Yeah, so when I see people that are going to the doctor, it's for more health management, not necessarily eating disorder stuff, but I work with a lot of GI and I work with a lot of hormonal issues and stuff. And then the many kind of complicated Venn diagrams that can go with that. And so a lot of what I do in preparing for people to go to the doctor or even afterwards is almost a little trying to neutralize the situation as much as possible of working through the anticipatory anxiety of like this is probably what is going to happen. And if this does happen, if the doctor says this or this to you, we're going to work through it afterwards, right? We can kind of put that in a little box and we'll compartmentalize it and then we'll
Mhm.
unpack it in the next session. And then also, working through if, let's say, their cholesterol comes back as high or their blood sugar comes back as high, we go through all of the different things of, hey, this doesn't mean that you are a moral failure with food or with exercise or all these other things. There are so many different reasons why your cholesterol might be high completely unrelated to food, or why your blood sugar might be high, completely unrelated to food. And so, kind of giving them a permission slip to not feel bad about what may or may not happen, but almost giving them a apocalypse plan for if the worst happens or the worst of what they think could happen at the doctor's office happens. Hey, we're going to be here. I'm here for you. Our clinical messages are always open, and you can send me a debrief of what happened. And I will say, even when I do that, I still hear some absolute horror stories of
Yeah.
what doctors will say just like offhand, not even realizing how that's going to impact. They're saying it in a very neutral way, but it is internalized and this was an attack on my moral being. So it's just trying to unpack and prepare in advance and basically giving them a rundown of like, hey, here's what's probably going to happen if your cholesterol is high, if your calprotectin comes back as high, if any of these things come back as high, we're going to work through it. And it's basically letting them know you have not failed in any way, regardless of whether or not you have gained weight, whether your lab markers have changed. And I'm so glad that you brought up the point of you don't have to agree to any tests or asking how will this change my care process, because that is something that I talk about so much, especially with my GI clients, because they may want to get a colonoscopy, endoscopy, all these different gastric emptying tests and everything like that. And so much of that is so stressful for people, especially colonoscopy. No one's like, yeah, I would love to wake up and get a
It
colonoscopy. And
sucks.
it's
Yeah.
just,
That
it's
sounds like a
a
fun
lot of my time is spent prepping people for colonoscopies in terms of like the mental preparation and what that works because especially from the disordered eating and eating disorder approach, that process is so triggering for people of the colonoscopy prep because you basically can't eat for a
Mhm.
day and you have to modify your diet beforehand. And there's a lot of misinformation around that as well. But yeah, it's a lot of, to wrap this up, neutralizing and also
Mhm.
empowering people to say you can say no to different interventions and also educating people on how on what the process really looks like and what the limitations on doctors are, right? They only get 5 minutes with you, right? There are certain things that have to go through if you want to get this visit covered by insurance, right? And just bringing the reality of that, I think can help neutralize things for people because we've been saying sometimes it really can feel if a practitioner says, "Oh, you've gained weight. What's been going on?" It can feel a physical attack even if it's just a
Mhm.
very neutral question of like, "Hey, have things changed? What has been going on? Have you been sick? Have you been stressed? Has your life changed?" Is what the intent of the question is, but the way that it's internalized is like, "Ah, I'm the worst person ever and this is why I didn't want to come here and this is why I hate going to the doctor and this is why I'm never going to come back here." And we kind of go into this spiral of anxiety while we're in the 5-minute session. And then it just seems like it's the worst experience in the world. So, trying to lessen that anxiety, neutralize the situation, and almost like desensitize them of the situation and what might be about to happen is generally my approach. But you said at the very beginning of this conversation, it's so different for every single client
Mhm.
depending on what they're going in there for. If I have a client who's just going in to get blood work so that we can go over it and break it down and see what might be going on under the hood is what I always like to
Mhm.
call it versus if have a client who has a very complex history of IBD and they also have hormonal issues and they also have a history of eating disorder and they also have all these other things, going to any practitioner is so much more of a fraught experience than someone who's just going in for a regular annual physical and who doesn't really have a history of going into so many different practitioners. So we're all just here to support you guys.
Yeah, and thank you. That's so helpful to hear about. I think I knew this, but it's helpful to hear it again because I'm not sure I really know it, right? For me, it's another day at work. And I think our training really tries to emphasize. I work a lot with medical students. We try to emphasize good communication skills, good listening skills. And yeah, it's tough. So thank you. That's all really helpful to hear and a reminder that just approaching with gentleness is so important in my daily work.
Yeah, I think Dana, I think we've kind of hit on everything there, and as far as what you can do to advocate for yourself and what that looks, and also too, having people on your team. And I think I honestly would encourage everybody to go check out your Substack. It is a wealth of information.
Yes.
And I
Thank
honestly think
you.
if you want to get to know doctors and the playing field that they're going into, this is a place to go, because I do think like, there is sometimes this idea of, oh, this is a problem, but they're also part of a ship too that they can't steer on their own either. And so, not to say, I really love that you said it's not the patient's job to fix the medical system, but it is all of ours. It's all of our problem. And if we want to change the system, we have to advocate and talk to our doctors. And I think you said demand better. And these
Totally.
are ways that you can demand better. And I think a way of understanding is by learning about what's happening and what they're dealing with in order to demand better.
Yeah, totally.
Yeah.
And vote.
And vote. Yeah. Yeah.
Yes, I'm a little late on that one, but yeah. But yeah, also be an advocate in your workplace. There's so many, it's such a huge part of our economy, and healthcare is a third of the US economy or something. And just, it's so complex and it's so enormous. So I think, yes, understanding a bit about the way that it works and how to take as much control as you can within that context, I think can be empowering.
Yes.
Absolutely.
Yeah.
Well, thank you so much.
Yes.
This
Thank you so much
conversation's
for
been
coming on today.
amazing.
Really, you guys are just doing so much good work. I'm so grateful for you. And I do want to acknowledge that doctors are really late to the size inclusive bandwagon. I have learned so much from the nutritionist community, from the mental health care community. Really, this was an activist movement that was started by folks in other professions, right? In the nutrition world and the mental health world. So I'm grateful for the work that's come before me and grateful to have you guys as allies, as colleagues, all trying to make it better.
Yes, thank you. Thank you so
Yes.
much. Well, one
Yeah.
thing that I always say to doctors when I'm advocating with my clients is part of the reason why I get to have these kinds of conversations is because I simply have more time with them. I have more time for them to talk about these types of things. And so I usually bring that in the thing. And I think that's the reality, is part of the reason maybe why they're behind is because they don't have the time to have these conversations because of the system at play.
Yeah.
Yeah.
Yeah, which is why we all need to advocate.
Thank you.
Yeah.
Yes, we
Thank
do.
you guys so much.
Yes.
Yeah, such a pleasure to talk with you both. So thank you. I write about the culture of medicine and parenting as a doctor on my Substack, which is called Chief Complaint. You can find it at maragordonmd.substack.com. And I'm on social media at maragordonmd. And I'd love to hear from you. I learned so much from my patients, from people who read my work. So please stay in touch. Yeah.
Thank you. It
Yes.
was
Thank you
wonderful.
again.
Yeah.